This could be because there are some still subtle differences in case mix across these units. This could be because there's some residual confounding that they didn't account for. But importantly, I think it's important for us to consider that there may be fundamental differences in the processes of care provided to patients who have acute kidney injury across these units. And this in and of itself, this variability in process of care, if it in fact exists, may be an issue related to quality. What is apparent is that we are utilizing more renal replacement therapy to support patients with acute kidney injury, in particular intensive care unit settings. This is data from the UK, clearly shows a trend of increasing utilization of renal support, but the same data has been shown in Canada, and the same data has actually been shown in the United States as well, is that we are now using more renal support in our ICU patients who have acute kidney injury. Michael Haas showed this slide. He went into some more detail about the NCE POD report, and I think what it highlights again is that the quality of care that patients who are at risk of or who develop acute kidney injury receive may be suboptimal. There's lots of deficiencies about the care that they receive that was clearly identified in the NCE POD report. And I won't go into those details again. But even follow-up studies that tried to look at the NCE POD quality indicators of care, if you like, again demonstrated that units were doing poor jobs at actually addressing the burden of acute kidney injury, in recognizing it, in managing it, in terms of its monitoring, its interventions, etc. Lots of lapses in care, if you like, that probably contributed to avoidable harm to patients. And you can understand a high burden of avoidable events and harm can be very costly to our healthcare system and very costly for patients downstream. In the 0 by 25 China Consortium study as well, there was a couple of things that I found very interesting. One was that the delayed recognition of AKI was actually not uncommon, and this contributed to worse outcomes for patients. Not only that, this and other studies have shown that non-referral to nephrology specialist care amongst patients who had acute kidney injury in hospitalized settings contributed to worse clinical outcome for these patients as well. So clearly in China, there would appear to be also issues around processes of care that maybe represent opportunities for us to improve the outcomes for patients with AKI. Now we can go back to the KDIGO clinical practice guidelines published in 2012, and we can look at the laundry list of things that we have tested in clinical trials to see if we can improve, either prevent or improve the outcome of patients who develop acute kidney injury. And I'd like to summarize it in one slide. Basically, all these interventions, the KDIGO clinical practice guidelines would say to us, do not use. The evidence is insufficient, either it doesn't work or it actually contributes harm by doing these things to patients. So what are we left with? If there's nothing that we can squirt, per se, into patients that are going to prevent AKI or it's going to reduce the burden of AKI, the bottom line is I think this should reinforce how vital it is to focus on improving the basic medical care for patients at risk of or who develop acute kidney injury to ensure they receive the best possible management. And I think this probably really reaffirms some of the conclusions of what Ravi Mehta made this morning in his opening address. Again, reinforcing basic medical care, focused towards avoidable harm. What are some of the short-term implications of patients who develop acute kidney injury? Well, in the ICU, if you develop acute kidney injury and it impairs your free water and solute clearance, you may spend more time on a ventilator. Not only that, you may have delays to weaning off mechanical ventilation. That causes you to stay in the ICU perhaps unnecessarily long, in particular if that episode of AKI was avoidable. Some of the short-term costs you could imagine, we do more investigations in patients who have acute kidney injury. They get a higher intensity of monitoring. They're moved to SDUs or intensive care units. They might have unplanned admissions to the ICU or prolonged stay. As I mentioned before, they failed to wean from mechanical ventilation. Their hospitalization is prolonged, and not only that, they have a high risk of early rehospitalization. Data supports all of these statements. What about some of the long-term implications? I think we've started to appreciate that the kidney, once injured and damaged, itself exerts longer-term effects after adjusting for all other relevant covariates, comorbidities, illness severity, case mix, etc., that the longer-term implications of a damaged kidney are beginning to be understood. Here's a nice paper from the Lower Mainland in Vancouver showing that the risk of, or the hazard of death over subsequently 10 years is higher for those that suffered an episode of severe acute kidney injury with their critical illness. We saw this graph already once today. The idea around incident, CKD, or rapid progression or acceleration towards end-stage kidney disease is now being clearly recognized as an important longer-term event following acute kidney injury, in and of itself with a lot of health economic and health resource implications. But not only that, quite a bit of data has emerged to suggest that patients who survive their episode of AKI in association with an episode of critical illness or an episode of acute myocardial infarction, like you see here, it's associated with the increased risk of other events, like major adverse cardiac events, major stroke, increased in patients who have AKI versus not and survive their episode. Not only that, the Taiwanese group, the NSARF group led by Vincent Wu, have done a remarkable amount of epidemiologic work showing that survivors of an episode of severe acute kidney injury are at increased risk for a whole host of downstream complications in the first 3 to 5 years following their incident episode. New sepsis, reactivation of varicella infection, reactivation of tuberculosis, fracture risk, cancer risk even. In fact, that's quite interesting. It gives you some semblance about the complexity of the pathophysiology of AKI and or the repair process that may occur. In this sense, there may be some issues related to the immune system function. You know, we all have cancers right now, and our immune system's probably taking care of them. But in patients who have an episode of acute kidney injury and survive, they may have some prolonged impaired immune function that contributes to many of these complications. We heard a little bit about quality of life this morning, and one of my fellows, Pierre-Marc Villeneuve, did this nice systematic review looking at the long-term quality of life among patients who survive an episode of acute kidney injury. A couple of things were clear. Their quality of life is impaired. More functional, physical impairment than mental impairment. If they had renal replacement therapy still versus had recovered their function, their health-related quality of life was certainly more miserable. That being said, these patients were often content, and as Eric Hoste highlighted this morning, if they were confronted with another episode of critical illness that might require admission to the ICU and support with dialysis therapy acutely, they would be willing to accept it. So the long-term costs of acute kidney injury for patients and for health resources, our healthcare system in general, new accelerated CKD or progression to end-stage kidney disease, and I'll talk about that a bit further here. Major adverse cardiovascular events, incident infections, sepsis, increased hospitalizations and health services use, impaired quality of life and impaired physical function. And the societal costs, which in fact, nobody's really addressed in any clinical studies as far as I could find to date, right? Productive years lost, employment, social assistance, life expectancy, the impact of acute kidney injury and whether recovery occurs on these elements from a societal perspective have not been actually adequately explored. How does acute kidney injury rank relative to other acute diseases that cause people to be hospitalized? So this is a study that's a little bit older now using administrative claims data, but it basically shows that AKI is sandwiched right there between stroke and heart failure in terms of its direct cost of hospitalization, at least in the US healthcare system. That's fairly impressive. Of course, England has done a lot to really evaluate the impact of acute kidney injury on healthcare and health resource utilization. And this is a nice, broad health economic study looking at the attributable costs of acute kidney injury in East Kent hospitals and then extrapolated for all of England. And what they found here is that the prevalence of AKI was around 14% of all hospitalized patients, about 38% of those who had chronic kidney disease. They suggested that their in-hospital mortality was 28%. And when they extrapolated this to England, they found annually that this represented an increase of about 40,000 excess deaths. You can see the costs associated with, in particular, excess hospital stays attributable to AKI was the largest driver of costs at £750,000 per annum. Critical care, unplanned ICU admissions, again, a major expenditure. Total inpatient care, hugely expensive, attributable to AKI. But not only that, once they left hospital, there was still a significant expense related to survivors of acute kidney injury, and this was largely related to patients who didn't recover their function, who had some element of CKD, who needed ongoing health services use over time. £1.2 billion. That's a massive amount of funding, right? If you think that a lot of these cases of AKI, in fact, could have been avoidable, you could see how a lot of those funds could be redirected for more efficient use in an integrated health system like the NHS. AKI is expensive. It's associated with increased risk of death, as I've told you, but prolongation of hospitalization, and in the US as well, excess hospital costs. This seems to be related to the severity of acute kidney injury. The more severe the episode, the more costly, if you like, the direct costs associated with acute kidney injury it is. And you can see that here. John Kellum looked at this in his cardiac surgical intensive care unit as well. He did a small matched study looking at expenses related to AKI or not. And you can see here across almost every expenditure, those who had acute kidney injury were more costly than those that did not. Okay. Similarly as well, you can see here stratified by severity of acute kidney injury. You can see clearly again, the more severe your AKI, the more costly it becomes to your health system. Of course, as well, and this is a study done a few years ago now in Canada, led by Braden Mans, and really looked at survivors of an episode of severe acute kidney injury that required renal replacement therapy in the ICU, and really did a detailed microcosting analysis of that. And what they showed was, look, if you survived your episode of AKI requiring renal support in the ICU, and you recovered to the point where you became dialysis independent, the expenditures that you incurred over the subsequent 1 year were completely marginal compared to if you did not recover and progressed to end-stage kidney disease. You can see the annual expenditures, 73,000 Canadian dollars, mind you, so that's like 15 or 20 euros probably, compared to 10 or 11,000 for those that recovered and were not on dialysis. And again, we have good evidence from the United States showing the incremental costs of incremental CKD stage and or even progression to end-stage kidney disease. Large increase in expenditures. Now, I'm just going to talk about this briefly because I know my colleague Stuart Goldstein will address this in more detail, I believe, tomorrow. But this is his NINJA study, and this is a quality assurance project that utilized an electronic alert that went to a pharmacist that used clinical decision support to inform about kids who were at risk for acute kidney injury because they were receiving nephrotoxic drugs on the ward. This is a non-ICU setting study. And basically what they found over the subsequent year or two of the study was that they dropped the rates of nephrotoxin exposure to these kids dramatically over time. But not only that, they actually decreased the number of episodes of AKI. They estimated that they avoided about 398 cases of AKI during the study. And if you think about what the costs may be for a single episode of AKI in a child, even if it's prolonged, increased monitoring, testing, prolonged hospitalization, unplanned ICU admission, whatever, even if it was $1,000 per episode, that would be close to $400,000. I could use that money to hire 6 research coordinators to do more work. Or that funding, if it was $2,000 per episode, could probably open 2 more pediatric ICU beds in their hospital for a whole year. Right? So these expenditures are not trivial, and these are cases of AKI that are clearly avoidable. Vilpatia and his colleagues looked at the societal perspective of incremental cost utility of providing renal replacement therapy for acute kidney injury amongst critically ill patients in the ICU. And here you can see the gained quality adjusted life years on the left axis and the cost effectiveness on the right axis. We use a threshold often of 50,000 euros to determine whether something may be cost effective or not. What they found was the cost per quality of life adjusted year was best for patients who were relatively young, who recovered their kidney function and survived for at least 1 year after their episode of AKI. If they failed to survive, if they were elder, or they failed to recover and they failed to survive a full year, the incremental cost, the cost utility was prohibitive for providing renal replacement therapy in an ICU setting. And here finally is some data perhaps in that context to suggest, look, there is some evidence to suggest that maybe initial renal support with continuous renal replacement therapy amongst patients who are critically ill with multi-organ failure may actually translate into improved renal recovery and dialysis independence. And if this is the case, there's a health economic argument to be made that CRT is more cost-effective, has a better incremental cost-effective ratio than intermittent therapies of renal replacement therapy, at least as your initial therapy. So to conclude, AKI is epidemic. We're clearly seeing a growing incidence, and this is not simply just because we're diagnosing it more commonly. but in fact, it's probably growing in its burden of incidence. We're using more renal replacement therapy. Its utilization is expanding as well. There are lots of short-term economic implications that you need to consider, be it testing and monitoring, be it ICU admissions, be it prolonged hospitalization, etc. There's also long-term health economic implications as well, particularly driven by CKD and progression to end-stage kidney disease, but also all the profound health services and other complications that may occur medically to these patients downstream. In general, health economic evaluations need to consider these downstream events rather than focusing on the acute event that might be more proximate to the episode of acute kidney injury. With that, I thank you for your attention.